So the topic given to me is the post-TKR instability. So let me quickly go through that. It's a standard textbook stuff, and then I really want opinion from the senior high-volume surgeons. How much is the problem that we have now? Okay, so complications, infections, periprosthetic fracture, instability. The third or fourth reason is for the revision is the instability. It is definitely getting better compared to, if you look at the overall trends in the multi-registry analysis, definitely the proportion of the reason for the revision as a polywear and instability is coming down, and infection and aseptic loosening is increasing as a proportion of the revisions. So there can be patient factors, technical factor. There's three different reasons. You can have a traumatic reasons like what Dr. Vakankar showed us a couple of cases, or implant type design, and there may be technical fault or malalignment as an iatrogenic fault. So these are all patient specific factors, implant related factors, and technique specific factors. So these clinical types we can, this talk first 5 minutes is meant for the relatively juniors as a textbook description. So it can clinically, what we need to see sometimes the three different types is an acute emergency, like a gross dislocation, subluxation. They come to the middle of the night with or without a trauma, or with a trivial trauma, without fractures or a major ligament avulsions. Obviously that's an acute orthopedic emergency, has to be dealt immediately. Next is a stage, next category could be a severe significant instability that compromises the activities of daily living. They cannot get on with that sort of instability. We need to immediately work on it, evaluate it, and do something about it. The third group is, I think, the most common group we all come across in our regular routine practice is this occasional but regular symptoms on a particular physical activity, when they get out of the chair, when they climb down the stairs. So that's the most commonest group, fortunately. The first two, I'll just brush it and concentrate on the third group. So acute emergency, you should do a neurovascular evaluation, fracture, ligament assessment, and then history, previous x-rays. All that has to be done by the EUA, has to be done when you are going to reduce it. So the procedure can be categorized into about 5 or 6 options you have. Close reduction, emergency EUA at the time when you do that, and try stabilize it and splint it and see how things go on. Or close reduction, EUA, and revision soon, because you on the table itself, when you reduce it, you know what are all the issues you are dealing with. Or close reduction, you can plan for a revision in the same sitting also. I mean, that could be a bit, can be done in a major centers, but majority of the time it's the first or second choices. Sometimes when you cannot do a proper reduction in a close means, you may have to open reduction of the spacer, particularly when there is a spin-off of the spacer, and at that time you do a proper examination to see what really made the instability. Otherwise, open reduction, if there is a repair necessary to be repaired, particularly quadriceps avulsion sometimes is a possibility, patellar tendon avulsion injuries that can be repaired, or patellar fractures can be repaired. Other thing, open reduction and revision on the same day. So these are all the ways in which these acute drastic disasters can be felt. The next is obviously you need to do a very, very thorough clinical examination, radiological examination, skyline view, stress view, CT scan, particularly to look at the femoral rotation. Try to make a specific etiology that why this is unstable. If you cannot make it something specific, if you can't pinpoint it, you may better don't hesitate to get a second opinion, because it makes a lot of difference. You can't just like that go on and revise it and expect things to be stable. You need to identify the villain and then do that. And any of these situations, the infection has to be ruled out. Okay, so these are all the severe instabilities. Fortunately, they are rare with the training and the better implant we all have. Okay, so now let's concentrate on the occasional but regular symptoms they have on a particular activity. They can carry on with their regular work, but still they are not happy, and they are afraid, they are scared, they feel insecure to to use the limb in a weight-bearing position and a particular activity. So go through the history properly, listen to them repeatedly, presence of any previous deformity, indications for the index surgery, complications after index surgeries, and then the specific surgical technique and processes what was used, and what exactly the physical activity that brings them climbing down the stairs, up the stairs, or getting up from the low chairs. These are all the areas, or sometimes when they get up, they stand, they feel like they are falling backwards. These are all the ways they describe it. So additional information, patient's pain, location, because there won't be anything obvious in the X-ray or a scan. These are all the situations you have to go through the history and clinical examination, and then there is a recurrent effusions which can be due to an infection also sometimes, but they may present as a instability. Specific description of the listening to that instability patient feels, definitely it makes a lot of sense. And examination, the routine clinical examination, the particular one is a 90-degree fall, 90-degree flexion. You check the anterior and posterior drawer test. So the pain at rest or extension, you may have a overstuffed patellofemoral component, and that make sudden pain that they may feel with the recurrent instability, particularly when they are climbing down the stairs. Sudden pop accompanying a feeling of a localized pain, it may be ligament rupture or a PCL in a CR knee. And once, a couple of cases I had in which a popliteal, they had a minor injury, popliteal tendon rupture, pain, and when they have a varus thrust, when she trying to turn to the same side, they get the postlateral pain, and then she was getting the instability. She was describing it as instability symptoms with the pain. So gave a local steroid injection, that became better. So like that, there may be some minute small things, some fibrositis all around that you have to repeatedly examine and go through that. So now let us come to the common topic of this flexion instability. Okay, that is the one what we need to concentrate, because all the other things has been discussed. So giving way upon descending stairs, not being able to trust the limb on an uneven surface. That's a made problem if they can't walk around in a lawn, and they feel insecure with the knee bit flexion from 30 to 60 degree. That's what we call as a mid-flexion instability. So the imaging many times may not give us any definitive information. The stress views, anteroposterior stress views in a CM fluoroscopy sometimes gives us a definitive. In a PSD, it may not go come forward, but may go backward. Antedrawer may not be, posterior drawer may not be positive, but antedrawer can be. The CT can give us about the femoral rotation. Now, I think presently we are all very, very familiar with the femoral rotation. About 20 years ago, that was not well concentrated at the primary surgery. So, skyline view, patella positioning will give us some information. So, additional standard, of course, at every stage the infection has to be worked up. So, the mid-flexion instability can be looked at as an extension instability. They go for an extension that can be symmetrical or asymmetrical, because if there is a varus middle side structures insufficiency, then it is called one side insufficiency, then it is called asymmetrical, or it can go as a extension instability. That is bit different from genu recurvatum, which we discussed in the last session, when the whole structure is going for a recurvatum. In extension instability is classically described when there is a collateral insufficiency that is giving presenting as a extension instability. The other most common discussed and described thing is the flexion instability. So mid-flexion instability from the range of 30 to 60, and then you have a global multiplanar instability. That one case was discussed like most like neuropathic joints. So neuropathic Charcot joints, not as classical as they was described in the books. We are getting a lot of subclinical which cannot be diagnosed by any of the means. And but we have seen quite a few ankle arthritis with or without fracture, without fixations, going in slowly. There may be asymmetrical, one joint involved. Neuropathic progression, but pathology cannot be assessed. That's also one reason. This thing. So that's the extension instability, and you can have a medial or a lateral post-operative insufficiency that is causing a that's presenting as an instability. So you have to see whether there is it can be repaired or you have to revise that. But unless you have a specific mechanical thing working on, you cannot. Sorry, there is some pictures. You can't just like that go and sorry, I can't see the, okay. That's fine. So you cannot go in without a plan. Okay, so undersized femoral component, rupture of the PCL and CRNAs, an excessive posterior sloped tibial cut, excessive resection. If you can see any of these, then you and the patients are lucky, because it's definitely you can go and address that, and definitely you would expect some amount of this thing. It's not forwarding. Okay, so the typical clinical sign is the posterior sagging sign in a 90-degree flexion. Make the patient relaxed, like your ligament testing, anterior and posterior testing. In PS implant, it may not sag, but it will come forward. So at that time, you have to look for hyperextension, other ligament laxity, like we discussed earlier in the case. The other thing, when they try to flex, externally rotate and put a socks, they get a popping sensation, they can't get up. That's you may have an additional combined lateral ligament laxity. All this has to be thoroughly looked in before going in for a surgery. Mild, maybe if you have only a 5 millimeter translation, anterior or posterior translation, you can work on the quadriceps, weight training, and some this thing you can try for some time. There is a possibility for a non-operative treatment. But when you have a laxity more than 10 millimeter, okay, definitely something has to be done, particularly in a active population. Maybe in elderly who are already on a stick or support, you may get away with a brace or so, but very, very unlikely, because it may cause a poly damage and they will come with a poly wear. If that can be prevented, it should be done. Okay, so this is a limited role, and initially you think the quadriceps is weak, they have not done the full workup. You can work up on that, diabetic control, all that, weight loss, all that initially can be done only if there is a femoral tibial translation is 5 millimeter or so. Okay, so guideline for revision surgery: locate the pathology and address that. Increase the posterior condyle offset. We are talking about mid-flexion isolated instability. Okay, and then if you can increase the femoral size, or you can posteriorize, or if there is both the sides, then you can increase the femoral. But temptation to go and simply change the polyliner, it can work out sometimes when you have problem in both extension and flexion. Okay, so if it is a stiff, then you can have a thinner liner or a thicker liner, but unfortunately that's not the case in most of the time. So if there is an FFD and flexion limitation, you can do all those things. But a classical mid-flexion instability in an active person do not get solved with this. You have to work out the pathology and correct it. So surgical management is easy if you know why is the problem. If it's not, if you are going there, then you will be obviously over constraining the joints. It's okay in a low demand elderly population, you may get away. Definitely in active population, you will have a problem. So the putting a very constrained joint, you may get away, but that may be a overkill, particularly in an active population. So that's the classical description in any of the literature you can see. And identify the villain, you will be very successful, or else you will be having problem even after corrective surgery. Thank you.